It is a pleasure to be here. Good morning, everyone. I do sincerely thank the Smart Train and the West African College of Surgeons for these teleclep series that have been quite enriching. Today we are going to look at a topic which is standards for reporting outcomes of cleft care. It is a deviation from what we've been having, which have been more of clinical series, but it's however germane to what we do as cleft care professionals. I have no disclosures to make. I do hope at the end of this presentation we will stimulate our focus on reported outcomes in our cleft care intervention, and hopefully we can collaborate more to develop standards for outcome research in cleft care in our region and our continent. The presentation will go through this outline. I will highlight the most common outcome tools that are out there for cleft care, and also talk about a health-related quality of life measure for patients who have clefts. Some food for thought and a SWOT analysis of our situation. So outcomes, essentially, other synonyms could be effect or impact. So in other words, what's the effect of our intervention on cleft care on these patients, or what's the impact that we're making? And outcome measures are designed to assess these on our interventions. And why do we need these outcomes? So we can learn from what we've done. If we review our outcomes, we certainly can improve our performance. We can learn from what other people are doing based on their outcomes, and certainly eventually have superior outcomes and have value for all the time that we spend on these interventions, and certainly provide more value or optimal value for perhaps all the money that Smart Train is putting into the care of these patients. Do we need standards? Yes, we do. We need standards so that we can meaningfully compare like with like, and to guide best practices in our region. We are familiar with this infographic on comprehensive cleft care, and I believe everyone here is represented in any one of these charts. And each of these interventions in the management of the patient with a cleft should have a focus on outcomes. When we talk about outcomes in cleft care, we're thinking in terms of what our interventions would result in. And these include normalized nasolabial and aesthetic appearance, intact primary and secondary palate, which are not just structural, but also functional, such that the patient has a normalized speech, language, and good hearing. We expect nasal airway patency, class 1 occlusion, good dental and periodontal health, and in the process and at the end of it all, have normal psychological development. Two eminent authors have elucidated that there is a need to assess outcomes in our setting, and they identified that there's also a need for standardization for improved outcomes for what we do. When we talk about outcome measures, they could either be primary or secondary. Primary outcomes, if we set out to study outcomes, primary outcomes are related to the primary objective of the study that we're doing. For instance, if we do a palatal repair, for instance, we may be looking at speech intelligibility as a primary outcome. But secondary outcomes for that kind of study, we'll be looking at perhaps perioperative complications vis-a-vis early or late repair of the palate. Outcomes could be quantitative or qualitative. We tend to do quite a number of quantitative outcome studies in the epidemiological reviews that we do, number of cases that are done, complication rates, but qualitative outcomes are more individualized to the patient and tend to address the problems and concerns of the patient in the process of attaining this intervention. The qualitative outcomes pretty much look at patient satisfaction. And indeed, patient satisfaction has now become integral to quality of healthcare and is now a serious consideration for quality, for improvement of care. These outcome measures could also be objective, in which we have tools to objectively measure them, or subjective, in which patients tell us what their experience is, or experiences are, as the case may be. There are several, indeed, a myriad of methods to measure these outcomes, from direct clinical anthropometry, in which the patient comes to the clinic and you take measurements depending on what you're looking for, to photogrammetry. Clinical photograph evaluation is pretty common. There are also more sophisticated methods such as 3D evaluation with spectrophotogrammetry methods too. But regardless of the method one chooses, if we're going to make it a standard, this method has to be reliable, easy to use, and applicable. Some of the methods are good, are quite valid, but cannot be used on a large scale. In Omari et al.'s review of the several methods of assessment of cleft-related facial deformity, they did identify that these methods are quite a lot in the domain, but there needs to be an internationally accepted method for assessing the facial deformity or any residual facial deformity of the patient with the clefts. And they propose that three-dimensional measures provide more information than two-dimensional tools. Now, I'll move on to the tools that are available. I'm starting with the Pennsylvania Lip and Nose Score, because it has been used by some authors in our region to assess their outcomes. The Pennsylvania Lip and Nose Score is a tool that looks at the lip form and nose form and grades the outcome into three, in an ordinal scale 1 to 3, 1 being very good, so 3 being poor. So the assessor is expected to look at the lip, and particularly the vermilion-free border, and assess if it's a good repair or a poor repair. And good repairs don't need revision, poor repairs will need revision, and that in between may need just a minor revision. The nose, in the assessor looking at the nose, the assessor looks at the nose symmetry, or the tip deviation, and also grades this into 1 to 3. Now, these authors use this to assess their surgical outcome and found out that they had overall good outcome, but they had poorer outcomes with the nose form. The plan score, however, was designed for assessing patients at conversational distance. And so it begs the question whether we can actually use photographs in making use of the plan score. Another score is the MCDADE score. This is actually the most widely used score out there for aesthetic outcome of unilateral cleft lip repair. The picture, which shows the slide, which shows the nasolabial complex, is what the MCDADE described, because they did find out that in development of this score, that judges tended to be distracted by the other features of the face. And so if the nasolabial area is cropped in photographs, judges can focus on this area and give their assessment. So they preferred use of this slide as well as a profile view of the nose. And they also graded they also have an ordinal scale from 1 to 5, 1 being very excellent and 5 being very poor appearance. The one thing with this MCDADE score is that even if we're going to consider adopting it, I realize that most of our pictures do not have profile views of the nose, and it may make it a bit difficult for us to use the Afieharo score in our setting. I have included the visual rating scale, which was developed because it was developed by two indigenous brilliant authors in in Nigeria, and they proposed this visual rating scale because they identified that the Afieharo score did not focus on any particular area. So it says have a look at the lip or look at the nose form symmetry without specifying regions of the lip that may be of concern. And it was because of this that the VRC scale was developed, and the assessors are made to focus on places like the white roll, the vermilion border, and presence of lip notching. And for the nose, the assessors are to focus on the flare of the nostril or the width of the nostril. This scale has, however, not been validated. Perhaps they require some form of funding, but it still needs to be validated for us to decide whether it will be useful as a standard in our setting. They, however, did agree that it's two-dimensional and will need to be improved upon to a three-dimensional scale for it to be acceptable as a standard for aesthetic outcome of the nasolabial area in children who have had a repaired lip, cleft lip. The unilateral cleft lip surgical outcomes evaluation scale is somewhat like the VRC, but in these ones, in terms of focusing the assessor on specific areas of the lip, like the Cupid's bow, the lateral lip, and the free vermilion. But they have provided, all these are also scored from 1 to 3 on an ordinal scale, but they have provided three-dimensional views for which the assessors will use to determine the outcome of the repair. Now, we look at dental arch relationship. I have here the GOSLON yardstick. The GOSLON yardstick is the most widely used tool for assessing dental arch relationships in children who have repaired unilateral clefts of the lip and the palate. In the development of this yardstick, it actually exemplifies the importance of adequate documentation of every intervention we make with these patients, as well as proper archiving of the records, because they took dental models of children who were 12 years old and had had little or no orthodontic intervention in their care. So they set out to categorize malocclusion in children who have unilateral cleft lip and palate, and they set to provide representative pictures of the severity of malocclusion that can be seen in these patients, as well as the difficulty in correcting this. And in order to do this, they chose 3 clinical features which they felt were most important in characterizing these malocclusions and of these in these children, these malocclusions that usually are seen in children with early permanent dentition. And they also have it on an ordinal scale from 1 to 5, 1 being good and requiring little or 1 and 2 really being good and require little or no orthodontic treatment, to 5 patient that shows that this kind of result would require orthodontic surgery. The GOSLON actually stands for Great Ormond Street, London, and Oslo. So it's involved 3 centers, 2 centers in Great Ormond Street. One had children who had NAM, and the other center, they didn't have NAM, while the Oslo network had no form of NAM. And they were able to identify that they had better outcomes from the center from Oslo, despite the fact that they hadn't had any form of orthodontic intervention. Now, we look at comparative studies that have used some of these tools. So Cleft teams in other clients have been able to use these tools to set their standards. And this study by Hawthorne et al. Decided to look at new Cleft centers that were established in the UK and see how well they conformed to the standards in that clime in terms of outcomes as well as record keeping. Now, this actually arose from the standards that were set by a clinical standards advisory group in the UK. And in this group, they had set standards at 75% exo. In other words, children born with unilateral cleft lip and palate, 75% of them should fall within Goslon's yardstick 1 and 2. You will see that in this study, they used the five-year-old index, which is actually like the baby of the Goslon yardstick, but the Goslon yardstick were for children at 12 years, but this five-year-old index is for children at 5 years. When they did this study, they found that 3 regions fell short of the standards. However, they noted that their outcomes improved from the previously reported outcomes. And they did question, though, that perhaps the 75% that they have set as their standard was probably too high a goal, but that will be determined by further studies. There was also the Eurocleft study. The Eurocleft study came as it's actually a 5-part study that came as a result of the need to standardize cleft care. They found out that there were over 129 cleft centers in a region and about 104 protocols for the management of cleft. In this part 2 of their study, they actually used the MCDADE score to identify the outcomes of the nasolabial appearance. And they did conclude that the cranium of the nasolabial appearance were satisfactory in most of the centers, and it's for centers that were less than satisfactory, they were not able to say really whether it was the method of repair that resulted in the reduced satisfaction. The Eurocleft study in measuring dental arch relationships also used the Goslon yardstick, and they confirmed that systematic differences in dental arch relationship occurred between different centers. And so they were going to move on to determine what causal factors were responsible for these differences in dental arch relationship between these centers. So this is how other teams have actually come together and used available standards to improve the quality of their cleft care. So the Eurocleft study was a 5-part. I mean, to conclude, in their 5 parts, they noted that measurement of clinical outcome in childhood was not only important, but valid for clinical audits. Secondly, they identified that inter-center studies provided more information than single-center reports. In America, for nasolabial aesthetics too, they used the MCDADE score, and they were able to identify no significant differences in nasolabial aesthetics, and they had an overall good to fair result, despite the fact that several centers use various protocols. A tool for speech outcome is the CAPS-A, which is the Cleft Audit Protocol for Speech Augmented. This protocol was developed in order to enable speech language pathologists across the UK compare their outcomes, and they identified critical points in speech that were important to determine the need for instance, ongoing speech therapy or repair of velopharyngeal insufficiency. And they looked at the score has intelligibility, voice characteristics, resonance, hypernasal or hyponasality, the presence of nasal airflow, the quality, the grimace or consonant production. And this CAPS-A score has been adopted, and it's a valid and reliable measure for use in English-speaking countries. However, it's been used also in America, and in using the CAPS-A score by the American Speech Project, they found that they needed to modify it based on some consonants and in their climb. The AmeriCleft Speech Project actually also highlighted how possible it is to use a tool, because they found that when assessors were trained on a particular tool, so these assessors were trained on the CAPS-A, and they found good reliability after this training, and so they were able to use it, particularly to determine parameters most important for evaluation of velopharyngeal function in these children who required speech therapy. There's also the AmeriCleft Speech Project. Now, what this resulted in was providing evidence that a tool such as the CAPS-A could be used for cross-linguistic studies. And this AmeriCleft Speech Project actually looked at three different languages: the Dutch, Norwegian, English languages in their region. And they were able to show that if they focus on, for instance, high plosive sounds and fricative consonants similar across those languages, this tool can still be effective for cross-linguistic studies. And this is actually particularly important in our region, where we tend to have several languages. The speech language pathologists, the SPAN group, can actually come together and determine what consonants are similar across the languages and come up with a tool that we can use and call our own standard. Now, all those tools measure objective outcomes, outcome measurements objectively, and which the assessor is going to use. But the International Consortium for Health Outcome Measurements, the ICHOM, their focus is on patient-reported outcome measures. And it is something that is now in the front burner of healthcare. We need to be interested in what our patients are saying. And their mission was to unlock the potential of value-based healthcare by defining global standard sets of outcome measures, which matter most to patients, and hope that this will be adopted worldwide and therefore have better value for all stakeholders in a particular healthcare area. And they do have something for cleft lip and palate. They have working groups from 44 different countries spanning different health related issues. And that's for cleft lip and palate. They also have adopted a tool, but we don't seem to have too much representation from Africa on that tool. They did state that there was a need to standardize the outcomes so that we can properly compare our outcomes in a meaningful manner. The tool that they have adopted is the Cleft Q, and it looks at the outcome in patients with clefts, both the burden of treatment and complications, as well as the degree of health. They developed this tool by interviewing patients across these countries to determine the things that matter most to them. And these were developed in a tool which is termed the Cleft Q. It has 3 overarching domains that focus on appearance, facial function, and health-related quality of life. The appearance scale looks at face overall, the lips, the jaw, the nose, nostrils, teeth, and lip scar. For instance, this section of the tool on the nose asks questions like, how do you like the length of your nose? How does your nose look when you smile? The size, how do you like the size of your nose? Do you like your nose in photos? So these are things that are really personal to the patient and things that we probably may tend to overlook when we are managing these patients. For speech function, they have like a distress, a skill that's as, is it hard for my family to understand my speech? I need to try hard to speak well. I need to repeat what I say to be understood. And it's graded. The patient is able to grade this, and one can score these values. The Cleft Q is developed for patients between 8 and 29 years. And of course, they should be able to read. For the quality of life skills, they have focus sub-skills like that look at the psychological aspect, school life, social life, speech distress. For instance, I have trouble reading out loud. I have trouble saying some sentences. I need to try hard to speak well. Those things that really bother the patient are in these sub-skills. And this Cleft Q is such that each sub-skill can be taken on its own, depending on what one wants to find out from these patients. Can we adopt a Cleft Q? It's not something we can answer now, but it is consideration if we were going to look at it and perhaps decide if we can validate it. But the Cleft Q-Study regions, although they had someone from Kenya, this map of their study regions doesn't give any highlight. The green highlights are the study regions in Africa, so we may need to do some validation. Now, the food for thought, I do hope the Smart Train team or those who put up this infographic will forgive me for putting this circle in the middle, because I think outcomes should really be at the center of what we do in comprehensive cleft care, and we should begin to think outcomes for everything that we're doing. If we begin to think outcomes right from the start, whenever we do decide to assess the outcomes, we will have the data that we need to assess our outcomes. And where is our focus in cleft care? Are we more outcome focused? Are we more how much impact we're making? Or are we looking more at our outputs than the outcomes? Or are we able to achieve a balance between our output, number of cases we're doing, and the impact we're making on the lives of these patients and their families? Certainly, when we look at standard outcomes, research and reporting, it will breed innovation. It will enhance the quality of care that we do. It will build trust in what we are doing, and certainly give us a choice on where to go for certain forms of intervention for these clefts care. So I have looked at what our possibilities are, and certainly our strengths and opportunities far outweigh our weaknesses and our threats to certain standards for outcome measurements in our setting. We already have a rich database in the Smart Train Express, which we can leverage on, because for instance, if we're going to use the MCDADE score, most of our pictures on the Smart Train Express don't have profile nasal views. And if we're going to assess CAR outcomes, most of the pictures are immediate post-op pictures, but we can develop this more to 6 months post-op, 1 year post-op. Let's have a photograph there that we can use when we want to begin to measure outcomes. We do have a high attrition rate, but if we don't set out to get these data in place, it's going to be difficult for us long-term when we start measuring or looking at our outcomes. The telecleft, it's such a great innovation as a fallout of the COVID-19, but it is actually something that we can also leverage on all stakeholders. It has effaced the boundaries in the continent, and centers can come together to decide what standards that are going to be used, what protocols are going to be used, what records are going to need to be kept, and then what outcome measures we're going to decide to use as a Cleft team in our region. There is the Nigerian Cleft Registry project. I want to believe that outcomes will be part of it. And then, of course, there's the Nigerian CRAN. We have these structures already in place for us to begin to talk about standards and outcome measures in our setting. So what are the take-home messages? Achieving optimal standards for cleft care across different countries is still an outstanding challenge, but yes, we must do it. We need to strive towards standardization of outcomes in a cohesive and readily interpretable way. Optimal standards of care is an imperative in comprehensive cleft care, and research and reporting using acceptable standards can only be achieved through collaboration of all stakeholders, which includes the patient and the family of the patient with the clefts. I sincerely appreciate the SMILE Train and the West African College of Surgeons. People actually build institutions. Everyone who's worked hard in these institutions to make every patient with the cleft have a smile. And for this series, I thank them. My base institutions, University College Hospital and University of Ibadan, I sincerely appreciate them. I appreciate and thank God for great minds in my teachers, Professor Oluwatosin, Dr. Ademola, Dr. Olawe, Dr. Inyu, who taught me plastic surgery and steered me in the direction of cleft care. And the little orthodontics or speech that I know is because of my ongoing friendship and collaboration with brilliant maxillofacial surgeon, Dr. Ajola Olusoya. I thank all participants of today's telecleft session for listening. Thank you.
Thank you very much, Dr. Michael, for a good job. We appreciate you. The lecture has been very, very insightful, and you have actually shared your thoughts with us on how we can move ahead to ensure that we have standards in the outcome of our cleft care in the country. Now the question, I have one question here from someone. She said, excellent presentation. How do we start assessing outcome in Africa? Can you hear me, Dr. Michael?
Yes, I heard you. First, we need to...
Okay, thank you.
Yes, so from what I said, we need to agree on what outcome tool we are going to use. And we certainly need to come together as stakeholders. We are diverse, but we can come together and agree on a tool. Then we can begin to assess the outcomes. If we don't have a protocol for documentation, it's going to be difficult. Right now, the widely used tool for nasolabial aesthetics, like I said, is the MCDADE, but it looks at the profile view. But most of us don't have profile views of the nasolabial area of our patients. So we need to come together and agree on which tool to use, validate it in our setting, and begin to record those things, components of the outcomes. Then we can start reporting outcomes in Africa. We've seen the Eurocleft, Afri-cleft. Nothing stops us from having an Ameri-cleft, there's a Scandi-cleft, there's Eurocleft. We can have an Afri-cleft group.
Thank you very much. I think there's another question from someone. In your opinion, what do you think and see as the most workable score for Africa or our context? I think Nicole would like to answer this question. Nicole? Hello?
Hello?
I think you wanted to answer this question. Or Dr. Michael, you take...
Yes, she should reply. She should answer,
okay,
please.
Question, Okay, let me repeat again. In your opinion, what do you think and see as the most workable score for African or our context? I believe in our context.
For the nasal, so there are different things. It depends on what we want to measure. For nasolabial aesthetics, the MCDADE, for instance, is the most widely used. So we need to pick a tool that we can compare across board. It's difficult now to say which is most workable if we haven't validated it. We need to take 2 or 3 tools and see how we can use it and then come out with one. If we use a tool that most people are not using, we cannot compare it across borders. So we still need to come together to decide that. It's not something we can make up our minds on now.
Thank you. There's another question, and it goes thus: as a surgeon, how do you assess outcomes in your hospital?
We assess in terms of, we look at the patient, we look at the pictures, and then decide, is this good or is it bad? But we haven't chosen a tool. So clinical assessment, we look, is this a good outcome? Do we need to revise? But if I report an outcome and say this was good or this was bad, someone in Northeast, North Central, or Southeast cannot relate to that if we don't have a tool to use. So in our center, clinically, we look at it. Is there a notch? We need to revise. There's no notch. We don't need to revise. But we don't have a specific tool that we say is our standard.
Thank you. Do we have any more questions? Any more questions for Dr. Michael? On the chat, everybody had actually congratulated you for a job well done, for a very good presentation. And the presenter next week, I guess that should just be directly to you. It says, on a lighter note, you have technically sacked my presentation for next Monday. Nevertheless, we will find a way. Kudos to you. I respect your brilliance. That's just on the lighter note. I think there's another question just coming in, and it says, in your opinion, what do you think and see as the most workable score for African? I think we've taken that.
Yeah. Yes, we have.
I think we've taken that. Yeah. Well,
there's another question.
Yes, I can see that. Is the profile view the same as the lateral view?
Yes, it is.
Is that question clear? Yeah.
Yes, it is. The profile view is same as lateral view.
Okay, thank you.
There's another question. Excellent presentation. How do we start assessing outcome in African?
Thank you.
To begin, we must have a protocol. If we are looking at dental arch relationships, for instance, every child who has had a repair of the cleft lip and palate should have the impressions taken at certain time points. So at the time of repair, probably at 3 years, at 5 years, at 8 years, at 12 years. Only then can we have data to assess outcomes. But if we're not taking all these, then it's going to be difficult for us to assess outcomes. For nasolabial aesthetics, how do we start? We can start by, we still need a tool. We still need to agree on a tool. I think it really can't be overemphasized. We need to come together to agree on a tool that we're going to use across centers for it to be meaningful.
Thank you. Any more questions, please? Well, if there are no more questions, Nicole, I'll hand over to you. Thank you very much again, Dr. Michael, for a beautiful presentation.
Sorry, Prof. Another question coming in. Sorry, another question. Do you have any publications on cleft lip and palate?
Oh, yes, I do. I have reviews. There's one on state distribution in our center, in our region. So where we looked at where are these patients coming from? Is there a cluster of patients? And we found a cluster around where we work, but it's difficult to say if there is, for instance, a causative factor, or it is because they are near the hospital that we have a cluster close to where we are. We also have done epidemiological reviews of the patients that we see. Those are the publications that we have so far.
Thank you very much. Nicole, over to you, please.
Thank you, Prof. I just want to precise one point. SmileTrend Express has the capacity to upload profile views and other views. So one can also record follow-up pictures. Just to loop in what Dr. Michael was sharing concerning the SmileTrend Express database. Yeah, so you have the capacity to upload follow-up pictures, like say 6 months later or one year later. You still have this possibility. So thank you so much, Dr. Michael. Thank you for this brilliant presentation. Thank you, Professor Ogunlewe, for the excellent moderation. Thank you, all of us, for attending this session. I wish you a lovely day, and see you tomorrow, 11 a.m. for another exciting session. Thank you. Bye-bye.
Thank you very much.